Yeah, my presentation is going to focus, as you said, on culture, context, and community, but similar to Mark, we made up the titles a long while ago, and I'd like to take things a little bit differently. What I'd really like to do is give a kind of a case study of Self-Help Plus in Uganda, highlighting elements important to culture, context, and community. And on the basis of that case study, think about next steps. So think about new directions from the research that we have concluded in Uganda, because I think those next steps are really closely tied up with issues of culture and context and community. So let me share my screen. It always all works excruciatingly slowly in a big meeting. Yeah, so like I said, I'll give a brief overview of findings of the Self-Help Plus work in Uganda. Just to highlight from the beginning that we looked at Self-Help Plus differently than you did in the redefined studies. We did not look at it as a prevention intervention, but we looked at it as treatment is a big word, but as an intervention that's focused on reducing psychological distress very broadly. I'll say a bit more about that later. And then I'd like to highlight 3 kind of unresolved issues or critical questions that need to be addressed, I feel. Before I start, I'd like to give big thanks to our partners in this effort. WHO, the implementing NGO Health Right in Uganda, staff and students at Johns Hopkins, Ministry of Health, UNHCR, Ross, who's joining us in the panel, Richard Bryan at the University of New South Wales, and Felicity, who's now at War Child. Thank you very much. It's been a great adventure doing this work together. The funds for the initial work came from a UN fund for action against sexual violence in conflict. But the piloting work and the later randomized trial have been funded by R2HC that Mark already mentioned previously. Very gratefully acknowledged. So just to give you a quick overview of the kind of work we've done on Self-Help Plus in Uganda. And I'll say a little bit more about Self-Help Plus later, but I wanted to start at the beginning. And the beginning really was a qualitative needs assessment. Then we went into a translation and adaptation phase. We spent a lot of time piloting the intervention, first through an uncontrolled pilot, just the very first tryout of the intervention, then a more controlled pilot focused on checking if our research and intervention procedures were really working like we were hoping to, more of a test run for the final study, which was a larger cluster randomized trial. And I'll go through each phase in a bit more detail, again, highlighting issues related to culture, context, and community. So the qualitative needs assessment was done before there was any talk about Self-Help Plus. The NGO that I was working with in Uganda was already providing services to South Sudanese refugees living in northern Uganda, and was doing that since 2008 onwards. And then suddenly at the end of 2014, the South Sudanese armed conflict broke out again. And there was a renewed influx of refugees into the region. And we really wanted to understand if our current services were appropriate in the changing situation and what kind of needs we should prioritize. We conducted a desk review, so a very targeted and not very systematic literature review, gathering existing information. We looked at the primary healthcare data that the UNHCR normally collects in refugee contexts. We did a 4Ws, a very quick and dirty who does what, where, and when, an overview of what agencies were providing what kinds of services in that specific setting. And we did qualitative, open-ended, semi-structured interviews with 86 individuals and individuals in groups. And what we really found was that people highlighted a lot of basic needs related issues. But the second priority out of any priority was overthinking. And overthinking was described as we are worried all the time. We cannot engage in our daily tasks, and we are continuously distracted from being doing our daily work because we are worried about if we have food on the table, if we're safe, if our kids can go to school, etc. Child abuse was a major issue listed, in ethnic conflict. The tensions that were brought into the refugee settlements were also highly prioritized. And overall, we found at that point that there were very limited mental health and psychosocial support services. So that was the context in which we were looking at alternatives for mental health and psychosocial support service provision. And we thought in which the intervention that WHO had developed would be a really good fit. And I don't want to say too much about Self-Help Plus because it's going to be the focus for future presentations today. But in very short, Self-Help Plus is a guided self-help intervention that's delivered in groups. It is not a standard treatment where you sit with a psychotherapist and have 8 to 12 sessions focused on a particular mental disorder. It is an intervention that you can do with many more people at the same time in workshops, using audio recordings, 25, 30 people in the workshop. You play the audio recordings. So it's really an effort to try to support many more people at the same time in a simple and quick way, in a standardized way, and focus not on one mental disorder, but on people with distress, regardless whether they have a mental disorder or not. So we thought that this was a good fit. The content of Self-Help Plus seemed to be a good fit for the issues that came out of the needs assessment. So we started with an initial translation and a very simple first tryout using mainly qualitative research techniques, consulting with community members. What language should we use? That was a really difficult point from the get-go, and it's still a difficult issue. Showing people the materials and asking them, what do you think of this type of intervention? Is this understandable? Is this culturally appropriate? Is this something that would be hurtful or acceptable, etc.? Then we ran just one Self-Help Plus group with men and one Self-Help group with women. The group with women went fairly well. The women were excited about it. They thought that was really good content that had the potential to help them. The group with men was much more difficult. Some of the men showed up under the influence of alcohol, and they started talking with each other through the tape. It was difficult to facilitate the process with them. So we decided at that point that we were going to continue the current research project with women, and that we would try separately to start a research project focused on men. We found that there were adaptations necessary, particularly to make sure that the intervention was much more interactive. Initially, we had thought about it more as a, let's get together and listen to the tape and do some exercises together. But the feedback really was we need to do more interactive group types of activities. So that was a challenge we had to think through. And we had to do some further work on the research end to make sure that we could do a good evaluation. I'm going to skip through the next feasibility pilot because I want to keep enough time. But just to quickly say that we ran basically a practice version of the study that I will discuss right now. We ran a practice cluster randomized trial, a feasibility trial. had to make some further minor adaptations, but overall things seemed to be running relatively smoothly. So for the final evaluation study, we conducted a cluster randomized trial already a while back. And we intended to screen in women on the basis of their scores on a short psychological distress screener using a score of 5 or higher, and actually ended up excluding only 5 women. This was a surprise to us. In the pilots, we had excluded more women on the basis of that criterion. And we also excluded women who were at imminent risk of suicide or who, and one woman showed signs of severe mental illness that we immediately assisted with more intense psychological and psychiatric support. In overview, I'll go from left to the right on this figure. In a quick overview, we randomized 14 villages. We randomized villages because we were afraid that if we would randomize individuals within villages, that people within a village would share the materials from the self-help recordings and also a self-help book that was part of the intervention. And again, you'll hear a bit more about the intervention in other presentations. But we were worried that people would share the book and the content from the audio recordings. So instead, we randomized villages, which makes a trial a bit more complicated, but we did think that that was important. 7 villages to the top line and 7 villages into the bottom line. And again, from left to right, we conducted a baseline assessment in each village. So far, villages were treated similarly, but then there was a difference. In the 7 SH Plus villages, we provided self-help plus through the workshops once a week for 5 weeks, as well as enhanced usual care. Enhanced usual care was a psychoeducation session with a community health worker, talking about thinking too much or overthinking and self-management strategies, and letting people know when there was MHPSS, mental health and psychosocial support services at the primary healthcare centers. And in the control condition, we provided only the enhanced usual care. Then in all villages, we measured women again, individuals again, after 6 weeks. And as you can see, we were able to follow up with almost everyone at that point. And we did that again 3 months after the intervention. And at that point, we, of course, were not able to find more women. More women were lost to follow-up, but still we're happy with how many women we were able to still track and again ask questions about their mental health. So this is a somewhat complex slide, and I actually really only wanted to show it to give you a broad overview. In every row is a kind of outcome measure that we included in the study. On the top is the primary outcome, and the rest are secondary outcomes. I'll go through them one by one. What you can see in the columns are the effect sizes immediately after the intervention, and the significance, statistical significance associated with that effect size. In the third column, you can see the effect size at follow-up, and also the p-value for that effect size. And if you just look at the table, you know, with one eye closed or with both eyes half open at a glance, you could see that the green values are the effect sizes that were statistically significant. So you can see that out of the 8 outcome measures, we found that for 3 there were no effects, and for the rest there were, including for the primary outcome measure. But I think what's more interesting in this table to see is that there's a very consistent pattern where for all measures, if you look at all measures, you see roughly a moderate effect size, something between 0.50 and or 0.30 and 0.70 immediately after the intervention, and a reduction 3 months later, where the effect sizes become small. Still significant, and we think still important, but small effect sizes in the traditional way that you can look at those. So to look a little bit more deeply into these findings, you can see that there are significant effects. So the people who participated in Self-Help Plus, they had better scores. They had better improvement over time than the people in the control groups for psychological distress, for PTSD symptoms, for depression symptoms, for anger, but also for positively phrased outcome measures, like if you can do your daily tasks, that's the functional impairment towards the bottom, and subjective well-being, where we see no effect is in how people interact with people in the settlements from other ethnicities. Our qualitative research showed, we heard people talk in the qualitative research about that participants in SH Plus seem to be greeting those from other ethnicities more. And we thought that was very interesting. So we included that as an outcome measure in the randomized trial, but we did not see an impact there. Also, we saw an impact on the self-defined concerns. That's the second outcome measure in this table. We did see an impact on the short term, but not on the long term. So the self-defined concerns was really an open question about the kind of priority complaints that the people themselves had. So an open question. And then we would track how difficult those problems were over time, before and after the intervention. And also, if you look towards the bottom, the third outcome from the bottom of the table, psychological flexibility, we saw an effect immediately after, but no longer at 3 months follow-up. And I'll get back to those variables in a second. With regard to culture, I think it's important to note that the intervention was perceived to be appropriate and helpful. We conducted a qualitative process evaluation. We haven't published that yet, but very interesting findings. Women were enthusiastic about the intervention. And you can see that in the participation findings. Overall, of the 331 women who were invited to participate, 89% participated in the first session, and almost everyone continued to do so. If you look at who participated in session 2, 3, 4, 5, you can see that it really hovers at about 80%. So women kept on coming. I think that's one indicator of cultural appropriateness, or at least acceptability of the intervention. I think these are interesting analyses. The moderation analyses, Self-Help Plus, as I described it, is a light touch intervention. It's only 5 sessions. It's delivered through audio recordings, many people in the room at the same time. So we were interested from the beginning to see if Self-Help Plus would be beneficial for different types of participants. For example, it could be that women with a history of sexual and gender-based violence would benefit less, or women with high levels of psychological distress would benefit less, or people who had been in the refugee settlement for a very long time may benefit less. And the moderation analyses actually showed that none of that seemed to be the case. The intervention benefits were not moderated by the number of types of different trauma that people had been exposed to, nor by gender-based violence exposures, length of time in the camp, or the severity of psychological distress at baseline. So overall, the benefits from Self-Help Plus did not seem to differ by different groups of participants, at least the different groups participants that we could look at. So again, from a contextual point of view, I think that's really important, because it could be that the intervention, a light touch intervention like this, has more contextually dependent or sensitive type of impacts, but we didn't see any kind of evidence for that in our analysis. So I just want to let you know that we are continuing to look at this data set. We think that the cost effectiveness analysis are really important, but they're also really complicated. So we're in the middle of that. Still collecting cost estimates from a wide range of things. Of course, we included cost estimates in our questionnaires, but we also need to look at costs at the, that the public health system in Uganda has, and potential benefits for individuals in terms of functioning regained and maybe even economic benefits regained. So we're in the middle of that. It's complicated, but we think that those are really important. We've done mediation analyses. We're keen on getting those published. I can share in a preliminary way that what we've looked at is very interesting. The underlying hypothesis for the intervention is that improvements in psychological flexibility are key. In fact, the kind of therapy that the intervention is based on doesn't necessarily think of itself as a treatment for symptoms or treatment of disorders. It really sees its prime goal as improving psychological flexibility. And our mediation analyses seem to support this emphasis, in the sense that, I should mention that that Self-Help Plus is based on acceptance and commitment therapy, or ACT, a modern form of cognitive behavioral therapy that that shares a lot of similarity with mindfulness-based psychological interventions that emphasizes dealing with strong emotions through grounding yourself in your in the present moment, but also living in accordance with your values. So even though you may live in extremely difficult circumstances, and the refugees that were part of the study certainly did and do, but intervention, part of it focuses on identifying what kind of person you'd like to be, what kind of things you want to do in your life, from a value point of view, and then finding opportunities to act in accordance with those values. And what our mediation analysis, to get back to those, what we could see is that indeed a change in an improvement in psychological flexibility in turn is associated with reductions on the primary outcome of psychological distress. So we see an expected mediation effect there that I think is important to highlight also from a cultural point of view, because it seems that the basic premise of this kind of intervention, that we find statistical support for that premise also in a very different type of context. I think that's interesting to note. Then I also promised to get back on the Cyclops outcome. The Cyclops is that self-defined concern, the open question around what are your main problems and how difficult are they for you? And then we track over time how much people score that difficulty. So what we did is a qualitative analysis. And again, these are preliminary analysis. We haven't published these, so peer review, I'm sure, will still qualify or even change these analyses, but preliminarily, what we did is group the types of concerns that people had. And there was a group who really highlighted, you could say, psychosocial concerns versus other kinds of concerns, for example, basic needs concerns or physical health concerns. And we could see that if people mentioned a psychosocial concern, they benefited more from the intervention. And again, from a cultural point of view, I think that is really interesting because it talks about a match between what the intervention proposes to do, and I guess you could say something like an illness narrative or a problem definition on behalf of the participants. That people who come into the intervention saying, I am thinking too much, or I have nightmares, or I have sleeping difficulties, or I have problems communicating, I have anger issues in the family, or I speak too roughly to my kids, or something like that. That those people benefit more from the intervention than people who do not mention a mental health concern overall. And finally, this maybe is a little bit confusing in the light of today's topic for the conference. But what we could see in our, this is the last bullet on this slide, what we could see in our analyses is that there was a large group of people with very high levels of symptoms, and that there was a group with more mild symptoms. So a question that came up for us is, are there any prevention benefits for this intervention? As I noted in the beginning of the presentation, we screened in almost all women. So you could say that this was, in practice, a universally delivered intervention. And yeah, we got interested as a secondary objective, as a post hoc objective. And well, for the women who came into the intervention with mild or moderate psychological distress, did the intervention help in preventing them getting worse over time, in preventing them from developing severe psychological distress? And a colleague, Dr. August Nabis at Johns Hopkins, has been leading these analyses together with Corrado and Marianne and others at the University of Verona. It's been very exciting to do that together, is to come up with a statistical way to see who actually has a disorder within the within our data set, and to then understand whether SH Plus has a prevention benefit. So we are working on that as well. I don't want to share too much about that since we're in the middle of that. All right, so then I have about 10 minutes, and I wanted to talk about 3 issues that I think we need to think about next. And the first step that I think is really critical is to go back to the very beginning of our project, the very first pilot of self-help in this community, where we found that men didn't respond so well. And we were very lucky to get funding for a project specifically focused on adapting self-help plus also for male refugees. Again, through R2HC, we're very grateful to have that opportunity. This study is currently ongoing. We finished the initial part, which was qualitative in nature, a human-centered design focused component, where we, again, got really just in touch with male refugees and asked them, what do you think of this? And how do men normally talk about mental health or thinking too much? And what are good ways of talking about these kinds of issues? We were surprised that many men came to us and said, hey, we've seen our wives go through Self-Help Plus, and if you would have told us that we would experience that much kind of improvement, we would have wanted to be included as well. Why do you not include us in these kind of interventions? So that was interesting to see. Men talked about things that we should do differently. For example, in places where you can meet men, the way we talk about mental health. But overall, I don't think that they suggested very substantive changes to Self-Help Plus. I think the very biggest thing we need to take into consideration is the amount of alcohol that men are drinking to deal with psychological distress. So that is going to be a very big pivot from a contextual and potentially, contextual point of view, that the amount of alcohol that's used to dampen psychological distress is really not consistent with the basic idea behind the intervention. So yeah, that's a change. We're going to, in the remainder of the project, see if we can pilot a brief and simple intervention for alcohol misuse next to SH Plus and see if there's some synergy. But we really do need to change course there compared to the plans we had initially. The second really important issue I think we need to talk about, and I'll do this quickly because I have about a minute or two left, is the drop in effect sizes. I do want to mention that that drop is similar to the drop you see in evaluations of other psychological interventions. For example, if you look at a Cochrane review that Mariana Purgato led, you can see effect sizes in this graph here drop very quickly from immediately after to 1 to 4 months after. And then again, 6 months after, less than half, the effect sizes really go down very quickly. I think an important question here is, is that a matter of doing more sessions or doing booster sessions, reminding people of the content, or is this maybe something that has to do with context as well? And yeah, I'm tending to think that this is a contextually determined issue. It has to do with how we have thought about mental health and humanitarian settings more broadly, that we think, in a clinical setting or in a program like this, we can provide psychological support, but then people, of course, go back to the environments in which the stressors still exist. Stressors related to poverty, related to gender-based violence, related to reduced social support networks, and then they may need treatment again. And Lund may talk about this later on, but what we really see is that this is a relationship that goes both ways. These are vicious cycles. For example, with intimate partner violence, a really important determinant of distress in humanitarian settings, we see that if you have experienced intimate partner violence, you're at a higher risk for depression. But if you feel depressed, you're in turn at higher risk of intimate partner violence re-victimization. And I think that this really calls for integrated interventions that address both psychological distress and social determinants. And what I think is really exciting about Self-Help Plus is that I feel for the very first time we have an intervention that can feasibly be integrated into the work of other sectors. Because if you take a 12-session individual CBT intervention to a poverty reduction NGO or a violence protection NGO, they will say, oh, that's too much. That you need to be a mental health NGO to do that work. We can't do that. But Self-Help Plus, I think, is actually an intervention that can feasibly be worked into poverty reduction or violence protection work. So I think that's a really exciting next step that from a contextual point of view is highly necessary. And then the last slide, a critical unresolved issue that Mark also mentioned, Mark van Ommeren, is, okay, now what? We have this evaluation study in a relatively controlled environment, but how do we actually scale this intervention up? SH Plus was developed as a scalable intervention, but it has been tested so far in controlled trials. What's next? So we're really excited in Uganda to see if we can take the intervention out of the trial and into routine large-scale programming through a capacity building trajectory with the Humanitarian Innovation Fund. We've thought a lot about this and we've come up with something called SH Plus 360, where we hope to in the future partner with humanitarian organizations in Uganda to think throughout the project cycle about that integration process. How can SH Plus fit into what you do as a large humanitarian organization? Sorry for the rush towards the end, but that's all I wanted to bring up. Thank you.